Hello, psychopathology class, and welcome to my final presentation. I am sharing my screen here in just a moment. You should see it pop up right there. Beautiful. So we will be presenting on somatic symptom disorder today. So let's get into it. So a brief background history of somatic symptom disorder. Forever ago, back in 1859, a gentleman by Pierre Briquet coined Briquet's syndrome. And this was way back in the day before we really narrowed it down. And back then, with Briquet's syndrome, a person would have to have a laundry list of problems, including headaches or chest pain, nausea and diarrhea, sexual symptoms such as menstrual issues, and a neurological symptom. And all of these conditions that were on this laundry list all had to be with no medical explanation. As time went on and language evolved, this later became somatization or somatoform disorder. Previously in the DSM-4-TR, which is the version that preceded what we use now, the DSM-5, there was a category of hysterical somatoform disorders which had actual changes in functioning. So, for example, you would experience things like paralysis in the legs, that kind of thing. This umbrella category had 3 disorders under it: conversion disorder, somatization disorder, and pain disorder with psychological features. As they went into sort of looking over everything and discussing and modifying the DSM for the current version, the somatoform/somatization disorder was changed to somatic symptom disorder, and included basically a better distinction to better aid medical practitioners in proper diagnosis, and to clarify that the absence of a medical explanation in and of itself does not constitute a diagnosis, but we'll get into that here in a minute. The other editing that occurred between the DSM-4 and the DSM-5 was the elimination of certain disorders such as somatization disorder, hypochondriasis, pain disorder, and body dysmorphic disorder. Somatic symptom disorder has a very interesting history. It was previously very sex-biased with diagnostic criterion that was almost exclusive to women and related to menstruation. And interestingly enough, if you go back super far, back to the ancient Greek times, they believed that women were the only people who experienced this hysterical version of somatoform disorder, and they believed that it was basically caused by an unsatisfied woman, sexually speaking. And it was believed that her uterus would move throughout the body and lodge in a certain part of the body, thus generating somatic symptoms. So just an interesting little historical tidbit. The prevalence of somatic symptom disorder is actually uncertain. Nobody really knows for sure what kind of numbers we're looking at. Although the estimates are somewhere between 1 to 19%, with an estimate of 5 to 7% among adults. Roughly half to over 75% of those experiencing somatic symptoms do get better with treatment for the symptoms and potentially any underlying things such as anxiety, depression, which we'll discuss later, while 10 to 30% who do not undergo treatment will actually get progressively worse and may in fact start exhibiting more symptoms over time. There is an assumed higher rate of prevalence among women, as women are more likely to report somatic symptoms, It's not really clear why this is the case. One could assume some cultural dynamics coming into play, but no one really knows for sure. There's also a possible underdiagnosis in elders due to a lot of stereotyping and assumptions. One of the assumptions is that illness worry is very common in old age when you're basically starting to get closer to the end of the line, basically. And actual symptoms, you know, you're getting older, your body's slowly kind of breaking down and not working the same way it used to. So the stereotype is that, oh, don't worry about it, you're just getting old. And so anyone who's actually experiencing somatic symptoms, they just don't get realized among the elderly. Youth prior to adolescence usually aren't very illness-centered. Actually, they focus more on discomfort. They typically complain of things like abdominal pain, headaches, fatigue, and nausea. So here is the diagnostic criterion taken directly from the DSM, the most recent one. And the diagnostic criterion is that criterion A, one or more somatic symptoms distresses the client and disrupts day-to-day life. And typically these symptoms do not have a medical explanation. They're just there and present and getting in the way of how you go about your day. Criterion B is the big central thing to this diagnosis. It's the thing that as counselors and counselors in training, we want to pay the absolute most attention to. And it is if the client is displaying any or all of the following: disproportionate and persistent thoughts about severity of symptoms, persistently high anxiety about health or symptoms, and excessive time and energy devoted to symptoms or concerns. So if your client is being crazy neurotic about the stuff going on in their body, this is what you want to pay attention to. One or more symptoms may not always be present, but the state of being symptomatic is and should typically last about 6 or more months. So we really want to look at that time frame when we're talking about diagnosing. If the symptoms are mainly pain-related, there does need to be a specifier of with predominant pain. If symptoms are severe and cause significant impairment, and again, this time frame we're looking at of 6 months or more, the reason we pay so much attention to that is to indicate the specifier of whether or not it's persistent. The severity needs to be indicated from mild to severe. Mild being one symptom of criterion B, severe being 2 or more of criterion B with multiple somatic symptoms. And the typical onset we're looking at for clientele exhibiting somatic symptoms is typically between adolescence and young adulthood. Keep in mind that there are always exceptions to the rule, but on average, this is what you're looking at. A few important factors to note, again, and I cannot stress this enough, lack of medical explanation for symptoms should not be the only reason for diagnosis. What is central to a diagnosis of somatic symptom disorder is the client preoccupation and worry over symptoms, usually to a degree that does not match up with severity. And we'll get into a more specific explanation of what that might look like with a client example later down the road. Symptoms do not have to be standalone. They can be related to a medical problem and can be specific or nonspecific. Evaluation of physical and mental health is useful to aid in diagnosis. So what that means basically is a person can in fact have a medical condition with or without these somatic symptoms. The somatic symptoms can be related directly to the medical condition, or they can be completely different. Again, Got to look at that neuroticism. You've got to look at that worry that is disproportionate to what is actually going on. Doctor hunting is very common with this disorder. Clients are often very resistant to what a doctor will tell them. If a doctor tells them, you're totally fine, there's nothing to worry about, you're healthy as a horse, what you'll see a lot of times is a client looking to get a second opinion, and they are very resistant to a referral for mental health typically, which is why you see this condition pop up way more in medical facilities, ER, things like that. Usually people don't go to see a counselor unless it's the absolute last resort. There is an increased suicide risk due to association with depressive disorders. There's a high comorbidity between somatic symptom disorder and depression or anxiety. So that is another thing to pay attention to when looking to diagnose. So here are some of the risk factors. I'm very reluctant to say causes, but these are things that basically will increase likelihood of somatic symptom disorder manifesting. And some of them are temperamental. There's that word again, neuroticism, front and center. Anxiety and depression are commonly kind of the cause or a contributing factor, or they can be a compounder of somatic symptoms. Another thing is you have to look at the environment. Somatic symptoms are more common to those recently touched by trauma or stressful life events, and are more frequent among low socioeconomic status. And an interesting little tidbit that I found in the DSM-5 is that in a family with a member having antisocial personality disorder, women more often have somatic symptom disorder. So, for example, if you've got, say, a mom, an aunt, a grandma with antisocial personality disorder, that does up the likelihood of another generation having somatic symptom disorder. And last is course modifiers. If there's a history of child abuse or adversity, if there's physical illness going on or social stress, all of these can be contributing factors to somatization disorder. Also, if a person is very sensitive to pain, very aware of their body, or if the symptoms are attributed to a medical illness instead of a standalone problem, that may contribute to somatic symptoms. A few cultural and ethical considerations to keep in mind. Somatization is much more common among non-Western cultures. It's a bit more socially accepted in these cultures, whereas Western cultures frown upon it. They have a very heavy mindset of, pushing through it, doing what you've got to do, and essentially ignoring symptoms entirely. Other cultures typically think of somatization as an imbalance of elements or a sapping of vital energy. Our Maddox and Weinstead text gives an example of the case of semen in the urine being a loss of vital energy. So that is something to keep in mind when diagnosing clients that may be of a different culture than the counselor. So here are some of the methods to generate diagnosis. These are all assessments that you can have a client take and look at the results to help confirm or add credence to your diagnosis. There's the Patient Health Questionnaire and Patient Health Questionnaire 15. There's self-report measures, 13 or 15 items. They're typically ranked by a client for level of botheredness from not at all to, oh my God, this is driving me crazy. The presence of 3 or more with this particular set of questionnaires indicates a diagnosis of somatoform disorders. There is kind of a shorter version of this, and that's the Somatic Symptom Scale 8, which is another self-report measure. Same thing, you rank your level of botheredness, and from what I've seen of these scales, from just doing a quick search on Google, the items are basically the same. It's a little shorter, like 8 items as opposed to 13. There's the Schwartz Somatization Index. This one has 11 symptoms listed, and if the client indicates that they have had 5 or more symptoms, then that will indicate somatization. And the last one that I decided to include in my presentation is the Scale for Assessment of Somatic Symptoms. The severity of symptoms is rated by the client on a scale from 1 to 3, and if symptoms present roughly on that same ranking for over 2 weeks, this would indicate somatic symptoms. Of course, this is just a few of the scales and assessments that are available out there. New ones are being developed all the time, as we know, but these are some of the ones that cropped up in my research. There is, ironically, just as there is a laundry list of potential things that you had to meet back in the day, way when this was the brisk condition, there is also a laundry list of differential diagnosis. So you want to be very clear and very specific on things like time frame and symptomology when you're looking to diagnose, so that you don't get somatic symptom disorder confused with differential diagnosis. So it could be another medical condition. Some examples include irritable bowel syndrome or fibromyalgia, which are what's called functional somatic syndromes. They are not medically explained by a disease, but they nevertheless do have symptoms. And I'll be touching on fibromyalgia a little bit later because it is relevant to this presentation. Another thing is depressive disorders. There is common comorbidity, but with depression and depressive disorders, they center around mood and inability to take pleasure in activities, whereas somatic symptom disorder is more centered around mood and neuroticism, centered around physical symptoms. So they can coexist. There's that comorbidity. But if you're looking to diagnose one or the other, this is the difference you'll be looking at. With panic disorder, both panic disorder and somatic symptom disorder present with high levels of anxiety and worry. But in the instance of panic disorder, the anxiety is, like, if there's any anxiety about health, it is not as persistent. In panic disorder, it's very episodic, whereas in somatic symptom disorder, it's kind of a constant thing. Generalized anxiety disorder, those who have generalized anxiety worry about everything, whereas somatic symptom disorder is way more specific. It's only about health and what's going on in the body. Illness anxiety disorder is in the sort of cluster of somatic symptom disorders and related conditions. But if worry is the dominant factor and no somatic symptoms are present, this diagnosis is what you're going to want to go with. Conversion disorder is way more focused on a loss of function. I mentioned earlier loss of function in legs or paralysis. If this was the focus, it would be much more inclined toward conversion disorder. Delusional disorder, the beliefs tend to be much stronger. than in somatic symptom disorder. To me personally, this sounds like almost the same exact thing. So as a counselor in training, I'm not really sure how to further explain the differentiation there, but there you go. Body dysmorphic disorder is far more concerned with the appearance of perceived flaws as opposed to actual physical well-being. And obsessive compulsive disorder does not have, or excuse me, there are no repetitive behaviors to reduce worry in somatic symptom disorder, whereas they are central to obsessive compulsive. So when we're talking about medication for somatic symptom disorder, there's really a lot of argument about how it is beneficial versus all of the walls that you're coming up against with prescribing medication. And this is all information gleaned from an article by Somachakhar, Jainer, and Wuntikal. And some of the benefits that they outline in their article about pharmacotherapy for somatization is that it is the most common treatment method, and it is an effective treatment regardless of the cause or what might be attributable to somatization disorder. And because it's one of the most common treatments and an effective treatment, it can basically kill two birds with one stone. As mentioned previously, somatic symptoms are often tied to undiagnosed depression or anxiety disorders. So if you're prescribing, say, an antidepressant like fluoxetine, this will not only reduce the anxiety or the depression, but by extension, reduce the physical manifestation of whatever's going on psychologically. Some of the barriers that you're looking at with prescribing medication are arguments over the cause of illness due to an overemphasis on psychological causes. While anxiety and depression are often present with somatic symptom disorder, it is not always the case. So there's a lot of argument that everyone thinks that, but it's not actually true. There is limited availability of psychological treatment, and there is competition between treatment methods. You've got one camp that says it's all about medicating, and another camp that says, no, it's all about therapy. Medication will just add to the problem, which does bring me to my next point on the barriers. Medication can exacerbate issues, as the side effects can be seen as further evidence of illness. And a client might see these symptoms and think, oh my gosh, my condition has gotten worse, and go even further into that neurotic worrying. Funding for research on interventions of this nature are limited, and I've actually seen evidence of this myself in looking at the studies of the different medications versus the placebos. There is a pretty small amount of groups that they've done the study on, but we'll touch on that here in a moment. And finally, medication is usually seen as a last resort rather than treatment. So there's a lot of dispute on whether it's, for lack of a better word, socially acceptable or not. That comes back to the whole thing about two different camps, medication versus therapy. So that's just some of the things that you're faced with when looking at this condition and whether or not to medicate. This is a list of some of the more common pharmacotherapy treatments. Antidepressants are the most commonly used class of drugs for somatic symptoms disorder. And some of the antidepressants that you'll come in contact with for clients experiencing this condition are amitriptyline, nifazodone, fluvoxamine, and fluoxetine. There are also antipsychotics, but according to an article by Kurlanczyk and Maffei, this is not ideal for treatment. And one example of an antipsychotic is levosulpiride. Hopefully I'm saying that right. And occasionally, if your client is experiencing seizures, an anticonvulsant might be appropriate, and that is topiramate. Many of these medications have been tested against placebos, which I mentioned in the previous slide. The sample sizes are very small. From my research, some of the sizes I've seen are 50 patients to 200, which gives you something to go off of, but in psychological studies, you're typically looking for a bit larger of a group. So for me personally, that did call some things into question. But what I really want to look at in this presentation is therapeutic treatments. Some of the therapeutic treatments that have been found to be very useful for somatic symptom disorder are cognitive behavior therapy, which, if you're not familiar with that, it's basically changing our thoughts in order to change our behaviors and beliefs. There's also mindfulness therapy, which means being present in the moment, being aware of what's going on in your body in the moment. And then you've got behavioral activation treatment programs. These are highly recommended for somatic symptom disorder, and it provides a recommended shift in focus from the symptoms to changing areas within the scope of control for the client and making area-specific goals, and has proven very beneficial in reducing anxiety. So many people, many therapists and counselors believe that by reducing anxiety, you can reduce the physical manifestations of that anxiety. And also this lends power to the client, or rather puts power in the client's hand, because while the client can't really change what's going on with their body, they can change the life circumstances that may have led up to the stress, the pressure, the anxiety that may or may not be generating these physical symptoms that we're seeing. Maddox and Weinstead also present suggestions to minimize the demands on medical care by the client. And this would be things like encouraging the client to build a relationship with one primary caregiver as opposed to doctor hopping that I mentioned earlier in the presentation. Seeing clients at agreed upon appointment times as opposed to whenever the client wants. This way the client does not become too dependent on the counselor and kind of supplanting, say, a physical doctor with a counselor and creating that dependence factor. Viewing physical complaints as a way of saying something else. So as a therapist or a counselor to your client, when you're looking at somatic symptom disorder and they are telling you about these physical things that are going on with their body, you've kind of got to pay attention to that and ask the client, tell me more about that, and really get to the underbelly of what is being said by what's going on in the body, like what might be causing that, what is going on in this person's life that is causing all of this. And I guess this is a little ironic looking at it now. We want to minimize drug use or analgesic meds. How I interpret that is we want to minimize self-medicating and make sure that we basically don't just chuck meds at our clients without also providing therapy. I came across an article that was very interesting in examining potential future changes for somatic symptom and related disorders. And apparently there has been some debate over whether to classify fibromyalgia as a mental disorder due to its factor of severe pain inexplicable by any medical condition. As I mentioned earlier on in my presentation, fibromyalgia is currently considered a functioning somatic condition. And the debate centers around if fibromyalgia meets the high anxiety and preoccupation criterion B for somatic symptom disorders. And this is particularly because the idea of what constitutes excessive worry over symptoms is very subjective. A study was conducted by Klaus, Fischer, Doer, Nader, and Muse just in April of last year. And basically what they did is they took 28 women with the fibromyalgia condition, and they gave them each an iPod, which would go off with a questionnaire at 6 predefined time points, typically right when they got up in the morning, then at like about 11 o'clock or so, and then late afternoon, and then night. And they would be asked questions about momentary pain, health-related cognitions and behaviors, and their affective state, their mood. And this went on for about 14 days, and then they reported back to the lab, did some more questionnaires, and the study was basically done. They looked at the results and evaluated them. And what they found was that the diagnostic criterion B for somatic symptom disorder would be fulfilled by almost everybody who participated in this study. So I just thought that was really interesting that we're possibly looking at fibromyalgia as a mental disorder in the next DSM. But I also acknowledge that this study has a very small sample size, so the level of seriousness of this study is a little questionable. I think it does serve to push for further investigation, but it remains to be seen. So now on to the fun part, my case study. I developed a case study for a client named Janine. Janine is a 28-year-old white woman who works as a graphic designer for Avon headquarters in London. She is working towards a promotion to creative director, trying to go for the big bucks. She has began having blackout, incapacitating headaches for what she describes as almost every week. And fairly recently, she fainted from a dizzy spell. Her symptoms have lasted for several months. She has seen 2 doctors, a neurologist, and has basically bounced around doctors at urgent care. The urgent care was basically at the behest of her boss, who was very skeptical of how many sick days she was taking. All of the testing that Janine has undergone has come up negative. There is no medical explanation for her headaches at all, and no pressing diseases, nothing. Janine is convinced that she has a brain tumor, despite the lack of evidence to support this. And because she believes so strongly that she might have a brain tumor because of these headaches and dizzy spells, she began missing work out of fear of limited time with her fiance. Even if she has not exhibited any symptoms on the days she calls out, she will still call out. Janine is facing possible termination because all of the doctor's notes that she has brought into her boss have basically said there's nothing wrong with her. She was raised by her aunt for most of her life after her mom died of a brain tumor. Dad was never in the picture, really, so there's nothing to really indicate anything there. Uh, Her mom passed away of brain tumor when she was 7, so it's been predominantly auntie. And her aunt is described as mean and hateful, very deceitful, caught in lies all the time, and extremely impulsive. On the plus side of things, Janine engages in Ayurveda. She does dancing. She's got an exercise routine. She's very social. She has friends in the LGBTQ community. She identifies as lesbian and is engaged to be married. One thing that I did not put in here simply for the sake of space was that Janine was described as very aggressive in high school and a bit of a loner. The school counselor did express concern that Janine might have had depression. Her aunt fervently denied it, and Janine was never evaluated. So something to look into if you pull up the longer version of my case story and the background information for Janine. The provisional diagnosis and criteria met for Janine. Janine has been given the provisional diagnosis of somatic symptom disorder with predominant pain, moderate. And the criterion that she meets is that she exhibits the headaches and dizzy spells that are worrisome and have disrupted her normal work patterns and social life. She's been skipping work and she hasn't been exercising as much. Janine's worries about her condition are grossly disproportionate to what's actually going on. She is concerned about having a brain tumor despite significant amount of evidence to the contrary. Again, all of the tests have come back negative. There is nothing indicating that this woman has a brain tumor. Janine has become so worried over her symptoms that she has begun missing work and is facing termination, which meets criterion B, number 2, which I mentioned earlier in the presentation. Basically, just disproportionate worry getting in the way of day-to-day life. Janine's symptoms mainly involve pain, which therefore justifies the specifier of with predominant pain. Some of the cultural and ethical considerations for Janine. Janine is a practitioner of Ayurveda, which, for those of you who don't know, is a healing practice involving the balance of elements, specifically the tridosha of Vata, which is air and space, Pitta, which is fire and water, and Kapha, which is water and earth. Bearing this in mind, it's very similar to what I mentioned earlier in cultural considerations of somatic symptom disorder in general. So utilizing this healing practice and gaining more information on it, if you come across Janine or a similar client, will be beneficial to building the rapport with Janine and conceptualizing her symptoms in basically her language. So, for example, if I were to counsel Janine or someone similar to her, I would conceptualize the headaches and dizzy spells as one of the corners of this tridosha being out of balance. Janine is female, which does elevate her risk of having or developing depression, which, as previously mentioned, is a common comorbid condition with somatic symptom disorder. 1 + 1 does not always equal 2, as I've mentioned, but it is something to bear in mind as a cultural and ethical consideration. And when I describe Janine's report about her aunt, it does suggest a possible antisocial personality disorder in her aunt. And because they are related, this would lend credence to a diagnosis for Janine of somatic symptom disorder. But that's something that isn't completely certain and isn't part of the end all, I guess, is the term I'm searching for. This is my recommended treatment plan. For the first goal, what I wanted to really focus on with Janine was minimizing her feelings of anxiety to avoid exacerbating the problem. And I want to make this very clear when I present this treatment plan to Janine, that I'm not saying she has an anxiety disorder or she has depression. The point I really want to drive home when presenting this treatment plan to Janine is that we don't want to make it worse. So getting into the nitty-gritty of how we accomplish that, first off, we have to elicit from Janine a commitment to schedule and attend an appointment within 2 weeks of the date of this treatment plan with a primary care provider of her choice for the purposes of obtaining a prescription for fluoxetine, not to exceed 60 days. So basically, we would be looking at a trial run of this antidepressant to sort of evaluate if it reduces her anxiety or keeps her anxiety to a minimum while she's worrying about the physical symptoms. And Janine's responses to the medication will be discussed in weekly counseling sessions every Wednesday to evaluate the progress of anxious feelings. And by extension, we might be able to also evaluate if her physical symptoms have gotten any better. Because as previously mentioned, antidepressants can be used to minimize the symptoms of somatic symptom disorder. So kind of a sort of backdoor way to seeing if this would be a sufficient treatment method for the somatic symptoms. Another specific objective toward achieving the ultimate goal of reducing anxiety is mindfulness meditation. So for our second, more specific goal, we're going to have Janine engage in mindfulness meditation for 30 minutes each day and write a sort of before and after comparison of her physical well-being to evaluate progress. These evaluations will also be discussed in weekly counseling sessions every Wednesday to determine if adjustments are needed, if she needs to meditate longer when she does this, or if she will need to meditate more frequently to reduce her anxiety levels. With goal number 2, this was really tricky. I wanted to present a goal that was very client-centered, very dependent on what Janine herself wanted to change. And as mentioned earlier in the presentation, what is recommended for somatic symptom disorder isn't so much treating the symptoms itself, but rather treating sort of the undercurrent, the life circumstances that may or may not be contributing to the physical manifestations of symptoms. So putting myself in the client's shoes, I started thinking, what would I want to work on if I was Janine, if I was wanting this really great promotion, but coming up against a roadblock, which is whatever's going on with me physically, mentally. So for goal number 2, I wanted to make sure that Janine takes appropriate measures to maintain employment and financial stability. Because putting myself in Janine's shoes, that is going to be super important. She's getting married to her beautiful wife. They might decide to have a kid later down the road. So how do we keep this a consistent thing, and by extension, possibly reduce anxiety or reduce the possibility of adding to Janine's plate and thus exacerbating the somatic symptoms? So getting into how we do that more specifically, we want to elicit from Janine a commitment to abstaining from calling out at her place of employment for 30 days. That's the entire duration of this tentative treatment plan. And the purpose is to minimize the risk for termination, try to get back on good terms with the boss and get back on track, basically. But we also have to consider for Janine if maybe the factor contributing to some of the things going on with her is that she's in a position that might be too stressful. as it is, or maybe too competitive. So bearing that in mind, we also have to present with a bit of a backup plan or wider options. So I wanted to have Janine commit to spending 1 hour each week on monster.com for 30 days, the duration of this treatment plan, to conduct a job search for a position that is still within her field. But again, we want to look at expanding her options and potentially reducing work-related pressures. So we're not saying that she has to quit her job. We want her to keep her job. We really want her to keep her job. But we have to be prepared for the worst. You know, plan for the best, prepare for the worst, or however that saying goes. So in conclusion, these are all of my references. I really wanted to push for more than 2 just to be on the safe side. And real quick, I do want to acknowledge, I am aware that the Ayurveda book is very old. It is from 1984. And I just put that in my reference list for the purposes of saying this is where I got my information about Ayurveda from. But I do acknowledge that that is way beyond the within 10 years limit. So apologies, but just to line my ducks in a row, there you go. So thank you very much for joining me on this novelization of a PowerPoint presentation. And I hope you all have a fantastic summer break and good luck with everything you endeavor. Thank you.